Let's jump right into it. Welcome to The Explainer. Today, we're unraveling a clinical mystery that's going to totally change how you look at treatment resistance. You know the feeling, right? You're doing everything by the book for a heart failure patient. You've got them on guideline-directed medical therapy, but they just keep getting worse. Well, pay close attention because we're looking at a condition that takes our standard heart failure rulebook and literally throws it out the window. Okay, picture this. You've got an 82-year-old guy on your service. He's carrying a diagnosis of HFpEF. He's on standard quadruple therapy, but he's bouncing back into the hospital with relentless congestion no matter how much you crank up those diuretics. So you look a little closer. His ECG? Super unimpressive, low voltage. But then you glance at his echo and boom, massive thickened walls. It's that classic low voltage, big walls mismatch. And that right there is a massive red flag.
So somebody finally orders a bone scintigraphy scan. The results come back and the scan just lights up. Mystery solved. This patient actually has transthyretin cardiac amyloidosis, or ATTR-CM. And here's the kicker. Once you make this diagnosis, your entire game plan has to pivot. You simply cannot treat this guy like your run-of-the-mill heart failure patient.
Which brings us to the big question. Why? Why are our most trusted, battle-tested heart failure therapies not only failing this specific patient, but potentially making things worse? Like, why are the clinical reflexes we've spent years honing suddenly so dangerous?
Let's get into Section 1, a restrictive filling problem.
To figure this out, we have to unlearn our usual reflexes and look at what amyloidosis is actually doing mechanically to the heart. In ATTR-CM, misfolded proteins, these transthyretin fibrils, infiltrate the myocardium. They basically pack into the heart muscle, turning it into this incredibly stiff, non-compliant chamber. Because it can't relax and fill properly, these patients become exquisitely preload-dependent, meaning their heart has an absolute, desperate reliance on high filling pressures just to squeeze out a normal cardiac output.
So you need a total paradigm shift here. Classic HSRF is essentially a floppy pump problem. It's weak, it's dilated, it needs unloading, right? But ATTR-CM is a restrictive filling problem. The ventricle is so stiff and packed with protein that its stroke volume is basically fixed. So they need that preload, and they have absolutely zero tolerance for anything that drops their afterload too aggressively, simply because they can't augment their stroke volume to make up the difference.
Moving on to Section 2, standard drugs to use cautiously. Because of this super stiff, unyielding physiology, our standard toolkit is full of landmines. The newly released 2025 ACC guidance explicitly warns us to be incredibly careful with three things we usually prescribe in our sleep. First, diuretics. Yes, you need them because congestion is a huge issue here, but avoid over-diuresis at all costs. These preload-dependent hearts will tank if you empty them out. If they're resistant, try switching to torsemide or bumetanide rather than just blindly doubling the dose. Second, vasodilators and beta blockers. Vasodilators wipe out that precious preload, and beta blockers, well, if your stroke volume is fixed, you rely entirely on your heart rate to maintain output. Slowing the heart rate down is a total disaster. And finally, ACE inhibitors and ARBs. They are notoriously poorly tolerated because of that severe afterload intolerance we just talked about.
Let's look at Section 3, HF therapies that still work. Okay, taking away all those tools might make you feel a little helpless, but it's not all doom and gloom. First up, MRAs. Mineralocorticoid receptor antagonists, like spironolactone and eplerenone. These are still very much in play. In fact, they're specifically recommended to help relieve congestion safely. Unlike your ACEs and ARBs, MRAs are actually pretty well tolerated by these stiff, amyloid-filled hearts. They are a solid cornerstone for symptom relief here.
And then we have SGLT2 inhibitors. Their story here is wild. Pre-2025, drugs like dapagliflozin and empagliflozin were explicitly excluded from the landmark Phase 3 ATTR-CM trials. We literally had zero randomized data. But fast forward to the mid-2020s, an observational cohort study started showing they were actually really safe. No hemodynamic harm, they protected the kidneys, and they provided a nice, mild diuretic effect. Fast forward to the late 2025 ACC guidance, and they are now explicitly endorsed right alongside MRAs for congestion, from completely excluded to highly endorsed in just a few years.
Which brings us to Section 4, disease-modifying amyloid treatments.
We are way past just treating symptoms now. The field has moved so fast, we actually have therapies that attack the disease right at the source of the protein misfolding. It's a two-pronged attack. On one side, we have TTR stabilizers, like tafamidis, and the newer one, acoramidis. These are daily pills that lock the transthyretin tetramer in place, physically stopping the protein from misfolding and depositing. On the other side, we have TTR silencers like vutrisiran. These are periodic injections, and they work way upstream at the genetic level, completely halting the production of the protein in the first place.
Now, you might be wondering which one is best. Honestly, no single agent has proven clear superiority across the board. Choosing often comes down to the real-world stuff like cost, access, and whether your patient wants to take a daily pill or come in for injections. There is one exception, though. Vutrisiran is the preferred go-to for patients with hereditary ATTR variant cardiomyopathy who also have overlapping polyneuropathy. Oh, and a huge point to remember, do not stack these. Combining a stabilizer and a silencer is not currently recommended. There's just no evidence that doubling up adds any benefit.
But if you take nothing else away, remember how you need to counsel your patients. It all comes down to 3 words: preserve, not improve. These drugs are incredible, but they aren't a time machine. They won't magically melt away the existing amyloid or reverse the heart damage. They slow progression. That means you have to get these patients started as early as possible to preserve whatever functional status they currently have before the end organ damage gets locked in.
Section 5. The new treatment paradigm. So let's bring it all back to our 82-year-old patient, the guy constantly congested on standard therapy. We're tearing down his old plan and building a new one based on these rules. First, cautious, incredibly tailored diuresis, maybe switching him to torsemide so we don't accidentally wipe out his preload. Next, we are pumping the brakes hard on those beta blockers and vasodilators, and most likely de-escalating them entirely, since his stiff heart desperately needs that heart rate and preload to function. Then, we can confidently keep him on or start MRAs and SGLT2 inhibitors to safely manage his congestion. And most importantly, we are immediately initiating a TTR stabilizer or silencer to actually change the trajectory of his disease.
So now that you know the hidden mechanics of ATTR-CM, how are you going to look at your next treatment-resistant heart failure patient? The restrictive physiology of cardiac amyloidosis totally changes which of your trusted tools help and which ones actively cause harm. Are you going to spot that low-voltage, big walls mismatch before you reflexively up-titrate their beta blocker? Getting this right is absolutely what changes outcomes. Thanks for hanging out with me for this explainer, and I hope it helps you rewrite the rulebook on your own wards.